Hello, I'm Janice Karen, Director of Integration Technologies at the Massachusetts Health Data Consortium, or MHDC. I run our Data Governance Collaborative, also known as the DGC. We start each of our weekly meetings with a series of industry quick updates to learn about new and proposed regulations, laws, standards, industry initiatives, and other activity. Join us for this week's updates. And if you'll go ahead and go to the first update, we'll get started with those. So our first item this week is AHRQ has released their 2022 Healthcare Quality and Disparities Report. Although they're calling it the 2022 report, excuse me, it appears that much of the data was through the end of 2020. And so a lot of the comparisons they do are for, or data that they provide is for 2020. Some of the highlights that they point out are around life expectancy, that not only does the US continue to lag behind other developed countries, the gap has been continuously growing since 1980. Life expectancy decreased for the first time in 2020, pretty much ever, for obvious reasons. However, the decline was less for non-Hispanic white people than for any other group, so that it widened the disparities. Which again also is not shocking given what we know. COVID was the third leading cause of death in 2020 after cancer and heart disease. I actually was surprised by that because I thought it was the leading cause of death. So that one actually surprised me a little bit. Another interesting thing, and I'm not suggesting that 12th is good, but the suicide rate actually fell, and it fell out of the top 10 causes of death in 2020 down to 12th. So I don't know, with all of the discussion about mental health issues at the moment, I don't know if that's gone back up since then, or if it's obviously that's still a bad thing. I'm not suggesting that it shouldn't be better and isn't something we should deal with, but I thought that was an interesting data point. And obviously there are lots of mental health issues that don't lead to suicide, thank goodness. So, but still an interesting data point. And the other thing that they pointed out is that there are quite a few specific conditions where outcomes in general have improved, and two that they called out with very specific good improvements were breast cancer and HIV/AIDS, but there were others as well. The disparities by race, income, and geographic location and a few other factors have either persisted or widened. So this report basically highlights something that we've all been talking about, which is that equity is an increasing issue, and in some ways it's getting worse and not better, although obviously the fact that we're aware of it and starting to work on the issue specifically will hopefully reverse that trend. So you can find more information at that link. And anyone have any comments or questions or thoughts about that? All right, let's move on to the next update. So this was interesting, and this came out earlier this week, and it was a surprise to me. HHS has released a new NPRM, Notice of Proposed Rulemaking, that allows increased access to an exchange of substance abuse data. I have only read the overview and not the full NPRM at this point, so there are some things in the overview that are not 100% clear. And one of them is whether there are they talk about substance abuse data specifically, but there are places where there are some implications in some of the overview that it might be more widely applying to everything that's in part 2. The goal of this is to increase care coordination and also bring this data more into alignment with HIPAA. So some of the extra protections around this data may be going away. And again, I haven't read the full NPRM, so it's not entirely clear what all of the details are. But some things that they highlighted in the overview that I looked at, which is the press release we linked to, is allowing one patient consent to cover all future use, including exchange of the data, disclosures that are for treatment, payment, and operations purposes. So if you consent once, my reading of what they said there is if you consent once, you're basically saying it's good to go everywhere, which is, somewhat problematic from a patient perspective, and we'll have to see. I think the devil's in the details there. And again, sort of along the same lines, allowing redisclosure, which again is once there's some consent, you don't have to consent to every disclosure. And in line with what would be allowed by HIPAA privacy rules for other data. And then the one that is a little bit more on the protective side is that they apparently have also increased the prohibitions on using this data for legal, administrative, legislative, and other types of administrative uses. So I don't know a ton more than what's on the page here yet. As I said, I haven't read the NPRM yet. I will be doing so. But that said, anyone have any comments, thoughts, questions?
I think this was a long time coming, and a lot of people were concerned that the Part 2 regulations weren't in line with the HIPAA privacy rules. So this seems to be a good step forward for patient confidentiality. I mean, the devil's in the details, and reading the NPRM will be the next step, but it's certainly a good indication of a positive change.
Well, I guess we'll have to, as you said, the devil's in the details. I see it more as not necessarily, I think it certainly would make life easier on the administrative side for the providers and the payers and the people who are looking to use this data for legitimate purposes. I am not convinced, without looking at the details, that it's a step forward on the patient side. We'll have to see what it is.
That's true. I can see that also.
So, and anyone else have any thoughts here?
Well, yeah. So substance abuse, of course, is one of the protected categories where, even if you release patient data, the substance abuse stuff is supposed to be withheld or masked or, otherwise treated extra special. So demuddying some of that, especially as it varies from state to state, will probably be helpful. Do you know, does this supersede state level regulation of substance abuse data?
Unless they explicitly say that it doesn't, which sometimes they do in some of these regulations, it should. Or sometimes what they do is they say this is a minimum bar. So if state regulations are tighter, then they can take precedent. But since this entire regulation would be opening things up more, I mean, in effect, what it appears to be doing is, whether it's just for substance abuse or for everything that falls under Part 2, they're either loosening or making steps towards getting rid of that distinction at all, is what it appears to, again, at that high level overview reading. So it's not clear, but a good question. Anyone have any other thoughts here? I think that realistically, probably to go into a lot more detail, need to read the thing, and I will definitely do that and present it to the group in one of our more lengthy deep dives into a topic. All right, let's move on to the next slide. All right, so here is another surprise, and this actually happened right before Thanksgiving. The House Ways and Means Committee sent a letter to HHS and the Department of Treasury and the Department of Labor, all the folks who oversee the No Surprises Act stuff, excuse me, pushing back against the updated independent dispute resolution process that's in the newest interim final rule that we have talked about in the past. This is the one where they changed the definition of the QPA, which I'm spacing out, but I think stands for qualified payment amount, but that could be wrong. Basically said that other factors could be taken into account. So this, what the Ways and Means Committee says is that the new rule, the rule that they wrote to deal with the court decision in Texas, actually violates both the law, the letter and spirit of the law that they passed, and the Texas court ruling. So basically what they say is that QPA should be one of several factors considered in an independent dispute resolution process. And that process is meant to be fair to both payers and providers and allow both to have a say in what gets considered. And the main thing that they're objecting to is something they're calling double counting. And what that is, you may remember that one of the things that the IDR entities, which are the people who resolve the dispute, must consider is whether the other factors that are raised besides the QPAs are already accounted for in the QPAs. And they say that figuring that out is difficult to impossible for the providers and for the IDR entities, that it's basically a black box and they have no idea how those QPAs were calculated, and therefore they can't comment or evaluate whether or not things were double counted, and that is a bias towards not considering them separately. So that's sort of the gist of what they say. At the bottom of the letter, they add a paragraph where they're very annoyed about the slow implementation of advanced explanation of benefits. They explicitly state that the law itself said that these were supposed to be implemented by January 1st, 2022, and that they didn't even get an RFI didn't even get released asking for more information until the end of September 2022. So they're like the gap is way too far. You're moving way too slowly. You must move more quickly. So it's a really interesting letter. And we'll see what comes of it, if anything. Any comments, thoughts there?
But this is a battle that's going to go along for, I'm sorry, go ahead, John.
No, Danny, continue.
This is war between payers and providers. And, whether it's the qualified payment amount, the independent dispute resolution process itself, there is one, I note that the American Hospital Association and the American Medical Association have been pushing extremely hard against the qualified payment amount and the way in which it's calculated. And I'm both not surprised, but I'm also I would argue that, in addition to the advanced explanation of benefits being accelerated, there are aspects of this that need to be accelerated on the provider side, which involve, price transparency, that involve, greater access to information for the patient. So it looks a little one-sided in terms of who they're going after in the whole scheme of no surprises, which is really both payers and providers have to go through a great deal of change. And it's kind of like saying, health plans, your disruption needs to happen faster than the disruption for providers, which strikes me as, I don't know if that's a fair assessment, but it strikes me as a little bit,
I wouldn't read it that way necessarily, Denny, because a couple of things. First of all, most of the components that are already in place are strictly on the provider side. So there is more being asked of providers at the moment, and some of the things that are provider only have already been implemented, are already, at least in theory, even if how well they're being enforced is a different question, but are in theory already in place and being required. Also, when they say the advanced explanation of benefits process, that's not strictly a payer thing, even though the payer is issuing that. That is a provider to payer to patient coordination thing.
Okay.
And so I believe
Yeah, but the
that-
provider is a fairly passive pass-through mechanism at that point, right?
well, the provider does the initial, to some extent, but there are pieces on the provider side. A lot of the reason for the delay is because of providers pushing back against the coordination of multiple providers coming together to do a single good faith estimate, is my take. So I'm saying there's glory and delay and, issues on all sides. But part of the problem, there's sort of a couple of different issues. And, on the provider side, part of what's delaying things there is not being able to get together and have all of the pieces of what's considered the single thing being estimated together. Now, that doesn't mean that there couldn't be some form of advanced explanation of benefits for a subset of services that are legitimately one provider. So I'm not suggesting that that's the sole piece that's holding things up, but it's the pushback that there isn't a standard format to send that data in. There isn't a standard mechanism for doing that. There isn't a standard. So there isn't standard agreement on what constitutes a knee surgery versus the whatever, which some of that work is ongoing. But I do think that I read that particular comment on the AEOBs to be not payer specific, but to be a comment on the entire process. I could be wrong. It could have been more. And obviously this letter is being hosted by the AHA. So clearly they are very firmly in support of it, or they wouldn't be posting it. But I suspect that's more on the QPA side that they're promoting. And the bulk of the letter was focused on the QPA and the IDR issue, that the slow implementation of AEOBs, although it was very pointed, was literally, a couple of sentences at the end. So I could be wrong about that, but that's my take. Go ahead, John.
It has some element of wishful thinking to it as well, because somebody who's worked on AEOBs, it's very complicated to do. Not to mention the ambiguity of specifically what should be included, what procedures should be included in a given AEOB. But just technically, it's hard to do, and you're needing to do it through hundreds of payers, large and small, across the country. So it's not going to happen as fast as folks might like.
Yep. And then there's other pieces that people aren't even really talking about. Like one of the ones that we like to mention at every chance is this idea that the patient gets to select the mechanism by which they receive the AEOB. And there's almost no one talking about that. And that's something that's actually an interoperability issue, because the patient's mechanism for starting this process is on the provider side. So the patient has to tell the provider what they want, and that has to flow through to the payer. And then that has to be obeyed, for lack of a better term, by the payer in order for the patient to get the format that they requested. And if that format is something that in theory, they're supposed to do it unless there's some major issue, but there isn't a clear mechanism. So there's all kinds of even small little issues that seem like they're a tiny portion of what has to happen, but they still require thought and effort and some level of interoperability and all of those things. So I agree that it's a complex process. Anyone else want to chime in? All right, well, that's what we had for quick updates. If you'll go to the next slide, Denny, and